Welcome to our second webinar, which is about adapting to our new normal. I think it's fair to say that prior to COVID, we as Emas UK had not established a major digital footprint. Like many other charities and patient advocacy groups, we had obviously used emails and had a website and some social media activity. But we certainly had not done any webinars or video content or a live virtual conference like this one. So it has been a rapid learning curve for the team. At the start of the lockdown, we saw the number of our inquiries increase by 95% at its highest point, where patients and families needed reassurance. Since then, the team has delivered a staggering 21 weekly virtual coffee hours since March. The number of those that attend are between 7 and 12, but those that do attend do so regularly and feedback positively about insights gained from the discussion topics. The trending themes has added to that of individual inquiries and the patient communities, and we hope eventually to hold these in each of the different patient communities that we are building. Last month, we also launched a moderated safe group chat for young people with IMDs on our secure platform. 6 have joined to date, and we hope to encourage more to join today via the Young People's Breakout session. 10 patient insight videos have been created, covering really important topics regarding the impact of COVID on taking part in clinical trials, attending routine hospital appointments, accessing urgent care, shielding families, patient and managed access agreements, managing home care, adult and supported living accommodation. And all these patient insight videos have been extremely informative and reaching around 5,000 views to date, including reach from other sharing on social media platform. We've had 4 different webinars, which has been particularly exciting as we've collaborated with other patient organisations and worked very closely with healthcare professionals and specialist sites in the UK. And these webinars have collectively reached over 10,000 views to date. So in terms of our proactive digital presence, we've increased our use of Zoom and all social media platforms, and building our communities digitally has facilitated a change in the way we deliver support, providing patients and caregivers with additional ways to access the team and the services that we provide. This more personal approach has enabled us to build strong relationship with our patient and caregivers, and also with the other partners, as I mentioned, in the sites. And working closely with these specialist centres across the UK has enabled us to make sure that we communicate a very clear and consistent message to help our patients stay well and safe. As we continue to upskill and identify the most appropriate ways to engage digitally, as this is part of the new normal, we will now need to make sure that we don't leave anybody behind, and that we start looking at also making sure that those that don't necessarily have access to devices and Wi-Fi and able to use all digital literacy are still being supported in the way that they need to do. But I look forward now to introducing our speakers and hear from their point of view how we adjust to this new world of ours.
Hello everyone. For those who haven't met me before, my name is Elaine Murphy and I'm a consultant in adult inherited metabolic disease at the Charles Dent Metabolic Unit at Queen Square in London. At the moment, I'm also the chair of the British Inherited Metabolic Disease Group. I've been asked to talk to you a little today about where things are with metabolic services across the UK at the moment and what we might expect over the next few months. So I think the best word to describe 2020 has been challenging. I don't think any of us would choose to come back to this year. It's been a very difficult 6 months for everybody, and it's we know that it's been a very difficult 6 months for many people with inherited metabolic disorders. Nonetheless, it's been great to see how people have tried to pull together and help each other through this. And we're going to need to continue to do that for the next few months. So one of the things that I thought would be useful to do would be look back at where we were when we did the last webinar, which was in June, and see where we've come to since then. So some of you may have seen this data before. So we did a survey in June across all the paediatric and adult metabolic centres in the UK, so including England, Scotland, Wales and Northern Ireland, asking how many of their patients have been hospitalised with confirmed COVID positive test. And across all of the paediatric hospitals, there's only been 5 children requiring hospitalisation. None of those children required any additional support with their breathing. There were no deaths, fortunately, and all of those children recovered. In the adult centres, there were slightly more patients admitted, as you might expect, because I think one of the things we've learned over the last few months is that COVID is a condition that primarily affects adults. So there were 8 adult patients with an IMD hospitalised. 1 patient required intubation and support with their breathing. Again, all of the patients recovered and there were no deaths. And when we looked at the disorders that were associated with these COVID positive tests, there wasn't any particular disorder that stood out. So the condition was spread across a number of different disorders. We're just doing that survey again. We don't have the data back from the paediatric centres yet, but we do know that there have been very few children hospitalised overall with COVID. With regard to adult hospitalizations, if you've been paying attention, you will see that these numbers are exactly the same. So far we have data back from our centre in London, from Cambridge, from Salford, Northern Ireland and Scotland, and there haven't been any further hospitalizations since June of patients with inherited metabolic disease and a confirmed COVID test. So that is very reassuring, really. Looking in a bit more detail about metabolic conditions where we know from talking to patients on the phone or meeting them in clinic or having video consultations that they've had a positive COVID test. These are the disorders where we know we've had patients who've had a positive COVID test. And again, spread across a wide range of inherited metabolic disease, including glycogen storage disorders, urea cycle disorders, fatty acid oxidation. Most of the confirmed COVID positive cases have been in individuals with PKU, and that is not at all because we think that PKU is a particular risk factor. We don't really think it gives you any extra risk at all above the general population. But for most metabolic centres, patients with PKU make up about a quarter to a third of their total patient population. So you would expect to see more cases because it's the most common inherited metabolic disease. We also asked centres in June what they felt about the incidence of metabolic decompensation and hospitalisation for metabolic decompensation, because one of our concerns was that a COVID infection would precipitate metabolic decompensation. So in other words, we might have more episodes of hyperammonemia or low blood glucose or metabolic acidosis. In fact, we found completely the opposite. So there were far fewer admissions than normal with metabolic decompensation over the peak of the pandemic up until June. And this is probably for a number of reasons, but these are probably the 2 most important reasons. We know that the protective measures that we're all trying to use against COVID-19 will also work against all other viruses and infections. So you're not going to get any respiratory or airborne virus if you're social distancing, hand washing, wearing masks, etc. So we have been protecting ourselves against more than just COVID-19 by taking on these measures. It's also clear from talking to patients and families on the phone that people have been looking after themselves perhaps a little bit more. They've been focusing on their health. They've been worried, so they've been taking their medications and supplements as prescribed and focusing on good dietary routines, and that has probably also helped. So these are probably 2 lessons that we can take forward and continue to try and reinforce over the coming years, because they are helpful against protection and against all viruses and infections, and just generally staying well. And although we haven't done a formal survey, in in the autumn, we are finding the same. So we still have fewer admissions than normal with metabolic decompensation. So again, keeping up with these protective measures is a good thing, particularly over the next few months. Some of you will be receiving enzyme replacement therapy by an intravenous infusion, either every week or every second week or occasionally once a month. And you will know that at the peak of the pandemic, back in March, April, May, we put enzyme replacement therapy on hold for many of the adults who were shielding because we felt that they were clinically extremely vulnerable and we were trying to reduce their exposure to visitors to the house. So there were a large number of patients in June whose treatment was on hold. I'm pleased to say that now the vast majority of these patients have been able to restart enzyme replacement therapy. We have a lot of safety measures and precautions, and home care nurses have put a lot of work into ensuring that they have appropriate PPE, personal protective equipment, and we felt it was the right thing to do to restart enzyme replacement therapy. And we know that some patients suffered and had an increase in their symptoms when their treatment was paused. A very small minority of patients have opted not to restart, but most people have restarted ERT. And it's also been good in that some patients have become more independent or semi-independent with their enzyme replacement therapy, which means they have less reliance on the home care nursing teams overall. A lot of people are asking if shielding is reinstated either nationally or locally or even for individual patients over the winter months. Will enzyme replacement therapy be put on hold again? And the answer to that is likely not for the majority of patients. It may even be that no patient will have their ERT put on pause. We still have to do final discussions across all teams, which is going to happen within the next couple of weeks. But the general feeling is that we can put enough precautions in place at the moment that we feel it is appropriate to continue with enzyme replacement therapy. Your own metabolic centre will be able to discuss this with you. And as I said, there may be individual circumstances, but in general, we will be trying to maintain enzyme replacement therapy for the majority of patients. There have been other changes, so not everything has been bad. There have been some positive changes. So this is a picture of a couple of our clinical nurse specialists who were able to very quickly organise to move patients who were on intravenous enzyme replacement therapy as part of clinical trials, and so we're having to come into hospital every week, and they were able to very quickly agree with the hospital trust, with the pharmaceutical companies, with the sponsors of the clinical trials, that it was much safer for the patients to move this back into their home rather than bringing them up to hospital every week at the peak of the pandemic. And so we're very grateful to everybody who worked together in order for this to happen. And that's been a positive benefit, I think, for those patients who've been able to reduce their travel to hospital. The middle picture shows the main entrance of our hospital, and lots of people did very nice things for us. And this was a local company who one day came and put balloons over the door, but that cheered everybody up grateful a lot. And then we've had a lot more interaction, I would say, over the last 6 months with Metabolic Support UK than we usually have, and that's also been a very positive thing, I think, for everybody. What about other treatments and monitoring? And again, back in June, there was really very little routine surveillance or monitoring for complications going on. And that had been effectively dramatically reduced while hospitals just got on with the business of dealing with urgent care and managing the large number of patients with COVID who were hospitalised in the first couple of months of the pandemic. And this was concerning for us as a speciality because we rely greatly on trying to prevent the long-term complications of inherited metabolic disease. And so by monitoring, we hope to pick things up at an early stage and to be able to intervene appropriately and to stop things progressing. So we have been trying very hard to restart this type of monitoring, but that has been quite challenging. And we also know that a number of you who had elective surgery planned, that unfortunately that was cancelled. And again, many surgical teams were only able to do urgent operations. Where are we at with that now? Well, what we call restoration of services has started. It is still rather limited, I have to say, and it's still quite variable across the country and even between hospitals in the same city. And this is because different hospitals have got different setups and are maybe in better or worse position to be able to start surveillance, monitoring, restart surgery in a safe way. So safe means if you're arranging to do something electively, you want to be sure that the person you're bringing in isn't bringing COVID with them into the hospital, which then becomes very challenging. And you want to make sure that anyone who's coming in for any investigation is protected and doesn't get COVID when they come in for either an investigation or surgery. So it's meant that we've had to change the layout of hospitals. We've had to reduce the number of people coming into hospital. Particular types of equipment need to be cleaned very frequently, and most equipment needs to be cleaned between patients, which reduces the number of patients that can be seen every day for investigations and surveillance, etc. So we're all having to look at our patient list, look and see who's waiting for testing, and then prioritise individuals based on clinical need. So if your echocardiogram, for example, has been very stable for the last 3 or 4 years and you have no cardiac symptoms, then it's likely you will go towards the end of the list. If it's known that you've already got some cardiac involvement and you've got worsening symptoms, then you will come towards the top of the list. And that's effectively what we're doing for most surveillance at the moment. With regard to delays in elective or planned surgery, again, these services have started to be restored, but we know that many patients have not yet been given a date, and it's going to take some time to catch up with the backlog. But things are moving forwards, and people are thinking of innovative ways of getting through the long waiting list. So it's likely that there will be, for example, more operations done at the weekend. There may be more use of private hospitals to do operations. There may be evening surgeries, depending on the circumstances in your local hospital. Outpatient appointments, I think as most of you will know, routine face-to-face outpatient appointments were in general completely suspended, particularly for adults, and replaced with telephone or video consultations. And over the first few months of the pandemic, only those patients who were deemed to be particularly urgent were being seen face-to-face. Most trusts are now moving towards reopening more face-to-face services, so the target is the same for everyone, to restore normal NHS activity. Many of us have started by trying to see all new referrals, so it's much easier to deal with someone by telephone or video if you've met them before. So most of us are trying to see new referrals face-to-face, and then other selected patients who may be more urgent or where we feel that we can't do the consultation by telephone or video for whatever reason. And we need to do all of this in the context of maintaining social distancing within hospitals. So that means keeping the corridors clear, having only a small number of people in a waiting room at any one time, etc. There's increased infection control measures in hospitals. So all the surfaces will be wiped down in an outpatient room between patients, for example. Any equipment used will need to be cleaned properly. And that includes things like the machine that takes an X-ray. And all of the clinic rooms in hospitals have now been assessed to ensure that they have adequate airflow and ventilation. And in some hospitals, particularly older hospitals, that may have meant that there were actually fewer clinical rooms available for consultation, which again is a challenge. All of us have struggled to maintain staffing numbers, particularly across the peak of the pandemic. Some services will have had their staff removed and put on the general COVID wards, or to help out in other areas of the hospital that were really stretched. Fortunately, I think most staff have now returned to the metabolic units, but again, we also need to maintain social distancing within the units themselves, and so there may not be as many staff in on any one day. There will always be now a number of staff working from home. Unfortunately, with modern technology, that is generally possible. So it all amounts to the same as what we said in June, in that fewer patients can be seen per day in outpatients, fewer investigations can be done per day, fewer people can be admitted electively, and so the waiting times for non-urgent issues will increase. And we realise this does put a stress on everyone, and we're all doing our best, I think, to work through this as best we can. And I think one of the most frustrating things probably for many patients has been you're given an appointment, then it's changed, then it's changed again, then it might be changed again, it might start off with a face-to-face, it might be switched to a video appointment, it might be changed to a telephone appointment. And that is really us getting used to the new systems, trying to be as efficient as possible, trying to work with often new administrators or administrators working across several services, but hopefully we'll get there. What I would say is, if you feel you are due an appointment and you haven't got something in your diary and you haven't heard from the hospital, because of all the chopping and changing, it is possible that you have been dropped off a list somewhere. So don't just sit at home and wait. Call up the administrators or the secretaries of your metabolic team, or get in touch with one of the dietitians, the clinical nurse specialists, or the doctors if you can get hold of them, and check. Because although we are doing our best and trying not to have anybody drop off a list, I think there's been a lot of administrative changes, and so it is worth checking if you feel that you haven't got a clear date for your next follow-up. So we have all had to get used to a lot of new technology. So suddenly overnight, we had the ability to do video consultations, dual screens appeared, lots of new software appeared to allow us to do things. Many of us are now able to see our work desktops from home, and there's been lots of new lingo, Zoom, Microsoft Teams, webinars, etc., that we never used before. And that has created its own frustrations. It's pretty good at work. So when things break down at work in the hospital, you can ring somebody up and a nice person in IT will talk you through the very simple thing usually that you've done wrong. But it's a bit more challenging if you're working from home. So I think all of us have been to improve our IT skills a lot over the last few months. So what's going to happen over the winter months? So at the moment, we are still in restoration phase. So as I'm sitting here recording this webinar, we've had a pretty bad week of increasing number of COVID cases. The universities have just started, the schools have returned, and we're all aware that there are a lot of cases in younger people. So the hospitals are now on alert with regard to that. But we were still working towards restoring normal NHS services, as well as having in the background the awareness that we may need to provide an increased inpatient COVID service over the next few months as well. So we're trying to do two major things at once, really. I'm trying to do that as safely as we can, both for patients, but also for the staff. So it's likely that if you're booked for an elective procedure, you're going to be asked to isolate at home for some days prior to your hospital admission. You're going to have to be tested for COVID-19 before you're admitted. Hospitals will have done things in slightly different ways, again, depending on their geography. Some will have designated COVID-free wards or even COVID-free buildings. There might be specific entrances and routes through the hospital. All of the staff in the hospitals will be wearing masks or additional PPE depending on the type of environment that they're working in, and the patients entering hospitals, carers, visitors, etc. will also be asked to wear masks. Again, if you've been anywhere near a hospital over the last few months, you'll know that the number of people allowed in the door is limited, and that is going to continue over the winter months. If you have been given a time slot for an appointment, it's really important that you would try to attend on time and not be late, because it's more likely than previous that you might be turned away, again, because of the numbers of people who are allowed into hospital and the way the outpatient clinics, etc., have been set up. And all of this is to try and avoid the reintroduction of COVID into hospitals and also the transfer of COVID to vulnerable patients. So people who are very well and just being routinely monitored probably won't be seen in a hospital this year. So the people that we're going to be asking to come in face to face are those people who we feel are unwell or need something doing or need to be seen. So they will be, by definition, be slightly more vulnerable. So really it's all of our responsibility to try and keep that group of individuals as safe as possible. And just looking really at the bigger picture, because although you or someone in your family probably has an inherited metabolic disorder, if you're listening to this webinar, actually that's probably one of the lower of your risk factors, and there are other things that are probably certainly equally, probably also more important. So our behaviour in general, whether or not we have an inherited metabolic disease, is probably going to be a big factor. But this little table here shows you where things stand at the end of last week with regard to, in this column here, it's showing you people who've been admitted to intensive care from the 1st of September, so essentially the month of September. And then the final column here is a cumulative column, and it's showing you the characteristics of people who've been in ITU with COVID since the beginning of the pandemic. And what you'll see is most people who end up in ITU are a little bit older. So the mean age of somebody in ITU with COVID is around 60 years. There are far more men than women in intensive care with COVID. So this is the situation this month, or in September. 70% of patients with COVID in ITU were male, 30% were female. And that has been the same throughout the whole of the pandemic. So being male is a risk factor compared with being female. And there are more people who are overweight and obese who are in intensive care with COVID than you would expect from the general population. So being overweight is a risk factor. And then we hear a lot on the news about comorbidities. Probably less important than comorbidities is age. So age is one of the bigger risk factors, but certainly specific conditions and respiratory disease, chronic respiratory disease would be one of those, would also be a risk factor. And at the moment, or certainly up until last week, these orange circles here show the number of intensive care admissions in different parts of the UK. Scotland is not included here. And you can see, you can almost draw a line halfway across that map. There are far more cases in the north at the moment than in the south. And obviously early on in the pandemic, there were far more cases in London than there were in the north of the country. So that has shifted slightly. And this is just looking at ethnicity. And what you are seeing here, really, this is probably the important bar here in the middle, is that there are more patients of Asian ethnicity admitted to intensive care than you would expect from the general population, and slightly more patients of Black ethnicity in intensive care, again, than you would expect from the general population. Shielding has been a huge topic for those who've been regarded as the most clinically vulnerable over the last few months. And it has been difficult. It is incredibly difficult to shield. To stay at home and isolate yourself for a number of months is a really difficult thing to do. Shielding, as those of you who have been doing it, has been officially paused and is still paused as we are recording this webinar. This is the website with the latest guidance, so you may want to have a look at this. This is from the 29th of September, but things do change very rapidly, so please do keep an eye on this, and if there are any major changes, we'll be communicating them directly to patients. So I'm not going to go through this in detail because it's quite a long document, and you can probably take your time and read through it slowly yourself. I did want to, just before I finish, say a little bit about the 2020 flu vaccination programme. So you don't want to get COVID, but you certainly don't want to get flu and COVID together. That would be a difficult combination, and you would likely be quite unwell. So the flu vaccination programme is being extended this year, and there should be more individuals should be offered the flu vaccination. So broadly speaking, most people who have been on the clinically extremely vulnerable list and have been asked to shield in the past will be advised to have the flu vaccination. I've put the website here so you can look at the list of conditions and the advice in more detail. And it's probably also important to say that this year there are additional people who are going to be recommended to have the flu vaccine. So if you're the main carer of an older or disabled person, you'll also be advised to have it, or if they're the household contact of somebody on the shielded patients list. So, for example, if you have a child who has previously been shielded and you are otherwise a young, fit and healthy parent, you may wish to ask your GP about the flu vaccination, because it is likely that will be offered to you. And finally, just to talk about what our future plans are. None of us have a crystal ball, and it's difficult to know what's going to happen in the next few weeks, never mind the next few months, etc. But there are regular ongoing meetings to discuss issues, where things are at, what we think we might need to change, what we think we might have learned over the last few months. So one of these hasn't yet taken place, but I think by the time you're listening to this webinar will have. So there's a meeting hosted by the Royal College of Paediatrics, to which we've been invited on October the 7th, and that's to review the current definition of children who are deemed clinically extremely vulnerable. And we will, of course, pass on any updates after that meeting. And then there's a meeting in mid-October with all of the clinical teams, paediatric and adult, the LSD collaborative, representatives from Metabolic Support UK and NHS England, to review our experience within inherited metabolic disease up until now, and to agree on how we will manage services going forward. And again, that may mean new communication to the patient groups and to you. Once we've had that meeting. There are also other things going on in the background, some of which are again quite positive. So some of you will know that if you live in more isolated areas, or not even particularly isolated areas, but just if you live some distance away from one of the metabolic centres, it can be quite difficult to get what we would consider in the metabolic field routine blood tests done, but to anyone else, your GP or your local district general hospital would be a specialist blood test and might be quite challenging to access. So this might include things like an amino acid profile or an acetylcholine carnitine profile. And COVID has really forced us to look at how we arrange access to these specialist blood tests. And then for us as physicians, if you do go and have a blood test done, for example, in Truro, then how do I see that result so that I can then act on it? So we've had quite a few meetings with Bionet, which is the network of metabolic laboratories, the BIMDG, NHS England, and the Royal College of Pathologists, to try and think about and work through that going forwards. And hopefully there'll be some positive changes. Unfortunately, I don't think they're going to be particularly quick, and probably not much will change in the next couple of months. But going forward, I think we will be able to improve that for patients in the future, and I think that will hopefully make it much easier to monitor individuals. We're also looking more at technologies that will allow us to monitor people from home in various ways as well. So I think that's most of the information that I thought would be most important to share with you at the moment. As you can see, there are a couple of meetings happening over the next few weeks, and as we get into the winter months, it's likely that there may be fairly rapid changes and more communication with you. So we will probably be back in contact again. But now I'm going to hand over to the next speaker.
Hello, thank you, Elaine, for your talk. I'm Izzy Caller. I'm the clinical psychologist in the Lysosomal Disorders Unit at Addenbrooke's in Cambridge, and I'm going to talk about mental well-being when living with an IMD during a pandemic. So the talks over these 2 days are around kind of themes of both patient involvement and kind of the new normal and lockdown and coping with COVID. So I'm going to talk about how people can be involved in supporting their own well-being in this current ongoing pandemic situation. I thought what I'd do is to talk briefly about what recent research says may help in these kind of situations, talk about what people actually seem to be finding helpful, and then to talk about how to get support from services if you find that you do need that. So before getting into all that, I'm just going to sort of lay out why the current times are stressful. As I think Elaine mentioned in her talk, there's a lot of threats to our well-being at the moment. There's threats to our health, kind of the issues relating to the potential economic downturn. For a lot of people, there's been reductions in available family support. Most of us find we can't do some of the things that we enjoy. There's been a lot of change. The new normal does seem to be change. So for example, perhaps being encouraged to go out and go to work and go to school when you've actually just adjusted to staying at home being the new normal. Now, the reason I'm saying this is because these things are all stressors, and the natural human response to the kind of situation we all find ourselves in at the moment is stress. So if you are feeling anxious or low, I just really want to emphasize that this is not because you're doing less well than you should be or less well than anyone else. This is because you're human. It's a natural human response to sometimes feel stressed and low and anxious in the current situation. And you're not alone. People all around the world are experiencing these kind of feelings. Can I have the next slide, please? Thank you. Okay, so there's been some research that talks about some of the things that might help. So there was a review of previous research into quarantines that suggested some things that were helpful. So for instance, that it's helpful to make sure that people are confident about getting the supplies they need, like food and loo roll, to make sure that people have good quality information, and to emphasize kind of altruism, that how people are choosing to quarantine to help other people. Now, obviously, the first two of these things are not really in our hands, the whole kind of good information and availability of supplies and so on. But I think the third one is interesting, the idea that focusing on the way that our actions safeguard and help other people also helps us to cope better. The second piece of research I've mentioned here, in this one, they were already collecting data on people's mood when the pandemic occurred, and they've went on and collected more data, and they've used this to look at how people's mood has been affected. And obviously, people's mood dropped because there was a pandemic. But really interestingly, they found that the process of recovery has already begun, rather than the dip continuing until the pandemic is over. People have already started to recover in their mood, a bit, not totally, of course. And that this seems to be especially true where people feel more in control of their actions and also like they're acting in a way that is authentic and true to their beliefs. And perhaps this may explain why altruism, like how you're helping others, helps, because altruism may help you to feel more in control and more autonomous about your own actions. I think it's also really interesting to note that people who are anxious at the start of the pandemic appear to have recovered more and recovered earlier. It's not really clear why this has happened. Perhaps it might be because this group of people already knew how to cope with anxiety about their health. Perhaps it's because it feels more normal to be anxious when everyone else is now talking more openly about it as well. I think that's a really interesting finding. Okay, so to move on to how this information can help us. Next slide, please. Okay, so I'm going to suggest some ideas that are based on this research and also some general ideas to promote well-being. So thinking about the research, autonomy, the idea that you're feeling in charge of yourself and your own actions is helpful. So this suggests that planning activities, even if those activities then get cancelled, is better than not planning them at all, because you're still in control of and making choices about your own actions. Also, making little choices where you can be helpful to foster a sense of autonomy. So the research suggested that one of the things that had helped people's mood increase was small autonomous choices that they had more of. So for instance, one of the things they mentioned was that you have more choice about what you wear if you're working from home, and that's one of the things that had supported people's sense of autonomy. So as I mentioned a minute ago, the idea that altruism, thinking about actions that help other people, helps to work against feeling powerless and thus helps you feel more autonomous. So planning in altruistic activities may be helpful, and also just noticing when you're doing things that are helping other people may help support your sense of autonomy. So to think about increasing your sense of authenticity. So this is the sense that you are acting in accordance with your own personal values. Something that may help here is when you're planning activities to do, thinking of things to do, is to try and think about why you're picking a particular activity. So why it might be valuable to you. So for instance, do you value it because it's good for your family or for your health, or because perhaps it's creative? And this may help because if you've thought about why you value an activity, then if you do have to cancel it or change it, it makes it easier to shift to another plan that might meet the same values, if you've thought about the kind of the reason that might be important to you. I think a good example of this is about self-care. I think people often find it really hard to prioritise self-care, and this can be easier to do if you think first about why it might matter to you to look after yourself. Again, for example, are you doing this because you want to be there for your family? Are you doing it for your own personal longer term health? That kind of thing. Okay, there's also some other more general ideas about things that support our kind of mental well-being. So an idea from positive psychology, which is the psychology of well-being rather than the psychology of illness, is about keeping a gratitude diary. So trying to notice each day, at the end of the day, 3 things that we're grateful about during that day. Now, I find it can feel a bit artificial to write them all down, so I don't keep an actual diary, but just trying to notice at the end of the day 3 things that you're grateful for can be really helpful. There's quite good evidence from brain scanning that this helps your brain to develop the habit of noticing more positive things and less negative things, which can be very helpful. There's a good website called Action for Happiness that I think can be quite useful. The other thing I've mentioned there is mindfulness. I don't think I'm allowed to be a psychologist in 2020 if I don't mention mindfulness, but there's lots of evidence that for quite a lot of people this can be a really helpful thing. The idea being that it can help you to notice more frequent worries or themes in your worries. So for instance, whether your worries tend to focus about going to work or sending your child to school, or perhaps about the availability of treatments or medicines. Not in order to try and solve these worries, because in the current situation, a lot of our worries just aren't things that we personally can solve, but just to be able to tolerate them a little bit more easily. There's lots of good mindfulness apps available. I think the Mind website is really good. It has some exercises you can do there for free that help with mindfulness. Next slide, please. Okay, so what about if doing mindfulness and doing these kind of things isn't really helping, isn't doing enough for you, and you're feeling perhaps that you just don't have the resources to cope from day to day? Perhaps if you find you're avoiding things that you know you need to do rather than, not just things you like to do, but things you need to do. Or perhaps if you've got persistent worrying that you just can't distract yourself from, maybe by watching the telly, that's just not working. Or if you find you're crying really frequently, so you're crying every day. These are the kind of times when you might think, actually, I think I need some help, something, from a professional to support my psychological well-being. There are local NHS psychological well-being services in every area nowadays. They're normally called psychological well-being services. They're sometimes called IAPT, which stands for Increasing Access to Psychological Therapies, but they'll be called one or the other of those things. They provide therapy, mostly CBT, counselling, webinars, information groups, one-to-one work. These guys are the experts in telemedicine in my kind of field. They've been doing it for years before COVID, so you can pretty much always see them without having to leave your house. They do very goal-based, directed work. You can self-refer yourself to a psychological wellbeing service. All you need to do is to search NHS Psychological Wellbeing Service and the name of your local area, and you'll find a website. You'll be able to self-refer either just by filling in a form or by phoning them up. If this doesn't work or you can't do that, if you just speak to your GP, they can refer you directly into these services, and they are often really, really helpful. Also, I think Mind are very helpful for people who are wondering about getting some help. They offer some virtual groups. They've got lots of really good information, and they actually offer a peer support service where you can talk to other people who have kind of anxieties or low mood. So if you are feeling like you're struggling with your mental health, I really encourage you to seek some help, because it is available, it is out there. Okay, thank you very much for listening. I hope this has been helpful, and I hope you enjoy the rest of the talks.
So hello everyone, and welcome to the impact of the pandemic on clinical trials and early access programs, and the importance of patient involvement. So my name's Naomi Litchfield and I'm delighted to speak to you here today. I lead patient advocacy at Bionical Emas, which is a clinical research organisation, often referred to as a CRO. So my background is paediatric clinical research nursing. I was inspired by my younger sister and the care that she received. She had 4 rare cancers and grew up in hospital, and it was ultimately compassionate use therapy that saved her life. So I worked in the NHS for 15 years and I've been in advocacy now for almost 5 years. When I was working at Great Ormond Street Hospital in London, I worked in the clinical research facility. I specialised in rare disease and worked on clinical trials and early access programmes. I was very privileged to care for patients and families with progressive conditions and very limited treatment options. So I administered investigational treatments, some of which transformed the patients' and families' lives. Some were metabolic conditions. I worked with Ashok Velodi and Paul Gisson, and I cherish my time working on the LSD trials. I was actually one of the first nurses to infuse ERT for Morchio patients back in 2009. And I was involved in then setting up the home care. So my current role, I conduct various patient-focused activities internally and externally, and I'm here to ultimately drive our mission of positively impacting patients and families all around the world. So just an overview of what I'm going to cover. So what is an early access programme? The impact of COVID-19 on clinical trials and early access programmes, how we venture into this new normal, and most importantly, what you patients and families can do to learn more about early access and clinical trials. So, what is an early access programme? There's lots of different terminology, which can be very confusing because different companies and different countries use different terms. But it is a pathway to access investigational medicine if you're unable to enter a clinical trial and there's no alternative approved medicine for you. And it's all about weighing up the benefit and the risk of taking that investigational medicine. So you might have heard different terms. Expanded access is the term used in the US. Special access is the term used in Canada. And you might have, I hope you've heard of the Emas scheme, which is our term that we use in the UK. Emas was set up in April 2014. That has many requirements. If they had to have a PIM, they have to have a scientific review, and I've been told that 1,500 investigational treatments have gone through Emas and been approved. So that's exciting. But ultimately, you must have a life-threatening condition and a clear unmet need. So you might have heard of managed access, an agreement set up with NICE and NHS England with pricing and reimbursement for collecting real-world data. And you might have heard of some of the different routes, so named patient, one patient, or cohort group, a group of patients, or a post-trial access after a trial has finished. And also umbrella terms like compassionate use and pre-approval access are terms used. Different organisations, one being the New York University, so they have a CUPA, so compassionate use and pre-approval access, CUPA. They are running a series of webinars at the moment around the ethics to expanded access in this current pandemic, and I highly recommend you listen to them. So, early access environment in the rare disease, why is it important to you? Well, as you know, at diagnosis, there's often limited treatment options, and there is more early access programs happening, and you patients and families are becoming more informed and asking more questions. Well, if there's no approved treatment and no trial, what now? So, as you know, the clinical trials are still the gold standard to getting these medicines approved, and we need safe and effective medicines as soon as possible. but they do have very strict inclusion/exclusion criteria. Even when they may go to be approved, and that's global market access delay, there might be a gap so that the post-trial access or an access program set up where it's going through the approval stage, and that could take 6 months, or it could take 2 years, and a patient might be eligible at the beginning of that time, but then 2 years' time they might have stopped walking or stopped talking or not able to see anymore, which is part of the inclusion criteria, and that's devastating. So we can collect data outside of the clinical trials on access programs, and that is referred to as real world data or real world evidence, and this is for the actual real life experiences outside of the clinical trials, and this ultimately helps inform and improve the future care of patients. So a bit more about real world data. So as I've said, the primary goal of early access programs is to get access, so to get the medicine to the patient as fast as possible with that unmet clinical need. However, as we're giving access, can we learn from this treatment? So if the patient is having bloods and observations and scans and quality of life questionnaires, if they were doing that in a clinical trial or indeed in their standard of care, why not take some of that data and collect it on an early access program? You could then publicise that and produce it as real world evidence and publish the paper, scientific publications, FDA and EMA directives, reimbursement, the different populations. Collecting real world data is a fundamental part of what we do at Bionical, running our early access programs, and we think it is a real opportunity to learn about that investigational treatment and in that condition. So it can supplement clinical trials, and I just think it's really important in rare disease, because rare disease, as you all know, there are limited numbers and there's a real need for urgent access. So if we don't collect this data while patients are on early access programs, then it'll be lost, and without collecting it we can't help inform the future care of our patients. So I just wanted to share with you today an interesting survey that I came across from UAudis, another fantastic patient organisation. They did a quantitative survey asking rare disease patients their thoughts and feelings around sharing their data. And as you can see on the right hand side, 97% of rare disease patients were willing to share their data to foster research on their disease. I mean, that's astounding. It's very compelling, isn't it? Find a Cure have even been tweeting that recently because it's such a powerful message, and I think we really need to get that powerful message out to all the sponsors, clinicians, regulators and payers, and be aware of this strong patient voice that they do want their data collected and used. This is really positive. And I encourage all patients and families listening today, if you do want your clinical information shared to help understand and treat your condition, then tell your doctor, tell your nurse, get them to document it in your notes. So if the opportunity arises to take part in a clinical trial or an early access programme, or indeed a natural history study, anything, that they know that and it's documented. I also wanted to highlight some of the other great work that UAudis is doing. They recently published a patient engagement toolbox for medicine in development, and I think it's brilliant. There's top 10 pharma sponsoring it and partnering. It's got valuable insights, and I encourage you all to read it. So, thinking about what Izzy said about being altruistic and improving our mental health, and how the community is very altruistic at the moment and benefiting the future care of patients, I wanted to share with you a personal moment in my career which will never leave me. I was taking blood here from Sam, who has a rare neuromuscular condition, Duchenne muscular dystrophy, and he was asking me a lot of questions about the investigational medicine, and he told me, I know the medicine may not help me, but I hope it can help the doctors and nurses to make other boys like me in the future better. So this message that Sam so beautifully articulated was very powerful and altruistic, and it really inspired me and still motivates me today to be a strong advocate for patients like Sam. And he knew at the age of 10 and still now at 15 in that photo that he wanted to benefit future Duchenne boys, and collecting his clinical information did that. And I just hope this highlights to you all listening today the power of the patient voice, and that we're here to listen. So, where we found ourselves here today in a global pandemic, and as you've heard from Elaine and Izzy, it is extremely challenging. I've heard this from a lot of healthcare professionals that I'm working with today and the patient advocacy groups. There's been a lot of adapting, a lot of change, and unfortunately, a lot of clinical trials and access programs have been put on hold. Recruitment has gone down, and as Elaine said, even routine surgeries or appointments have been put back. But if you haven't heard when they are going to go ahead, please get in touch with your doctor. As Elaine said, this is really important. And I think, delays in data collection and most importantly treatment and diagnosis is a real concern, and it is worrying, and we need to address that. I think we're fortunate at Bionical that our clinical trials and access programs continued and all medicines got to patients, but there was a dip in new patients, and I hope not to see that again as we go into winter. I think we need clinical trials to keep running. That's the only way we're going to get safe and effective medicines to the metabolic community as quickly as possible. But we also need to keep all patients safe in COVID-19. There are more early access programs happening for COVID-19 to actually treat it. So sponsors are looking at that, and if their current pipeline, and say it was in a rare disease, can help treat the current pandemic. And I think, speaking to rare disease communities, there is a real concern that these pharmaceutical companies that are developing investigational treatments for, say, metabolic conditions, may be then having to use some of their medicine and resources to treat COVID-19. However, the companies that we're working with are doing everything they can to ensure that's not at the cost of patients, and that they're equally sharing their pipeline medicine for rare disease patients and COVID-19. And I think resources need to be the same, because mountains are being moved to treat COVID-19, but mountains should be moved to treat rare diseases. I think that patient shielding is really challenging, of obviously going to the hospital and the travel and the infection risk, and taking part in clinical trials and early access programs, and the pressure on the healthcare professionals, as you heard from Elaine. As she said, bear with us, it's really challenging, it's hard, and there's some tough decisions to make. These clinicians have patients on the ward, have patients in a clinical research facility, and now have some patients that they need to care for in intensive care, and it's hard. So what can we do? Thinking about things that we can put in place and how we can adapt and learn and reflect and be as proactive and positive as we possibly can. Can we put things in place to be in our new normal? So home care is the first one that I think of, and I'm a strong advocate for, if it is possible. The International Gantche Alliance on the 1st of October, as you would have seen, shared some inspiring stories from their patients receiving home therapy, and how it gave them freedom and comfort, and there was no travel and infection risk, and being in their own homes, and how they much preferred that. It was very positive. So if we can get some clinical trials and access programs to home, let's do it. Data collection can also be done at home. As you know, you can do videos with your doctors, as Elaine showed you, and there are new wearables now and apps and smartphones that we can use to collect data on clinical trials and access programs. As you know, Ellen's incredible company Aparito, their digital technology is bespoke for that condition. So I hope more companies will be partnering with Aparito, and more digital technology will be used in our new normal. We want to reduce the burden on our healthcare professionals and our patients and families. And other ways of doing that are aligning our clinical trial appointments and our early access appointments to routine visits, or when the doctors are looking for the data and going through their clinic notes and making sure that they don't have to do extra visits for research and access programs, that they have their standard of care alongside their same bloods and infusions and observations and scans. Sharing data, healthcare professional, there's lots of papers being produced. Can we share more of that for our clinical trials and access programs? There was a paper only on the 8th of September from CTAP. They were talking about utilising real world data to supplement or replace some placebo trials. That's fascinating, because placebo trials are really high burdensome for families. So share that, speak to each other, healthcare professionals and the patients and families. It's really important to keep yourself safe, and as Elaine said, speak to your doctors and get your flu jab. That's really important for this winter. So what can you, patients and families, do to find out more about clinical trials and access programs? Well, first thing I say is speak to Metabolic Support UK. That's what they're here for. That's what they do. You all have a rare condition with a common fight. They're an amazing advocate. They're here to support you. They have lots of knowledge, and like Izzy and Elaine so greatly said, they're here to look after your mental and physical health. You speak to all your doctors because they are expert in your conditions. So not your GPs, your doctors that are your metabolic doctors that are treating you. They are your experts. They will request access if they can for early access, and check out the company websites. So they will have early access policies. They'll have their pipeline, so you know what phases the clinical trials are in. You can check out clinicaltrials.gov. However, be mindful that it's not always up to date, unfortunately. I urge you to engage with companies, regulators and payers. They want to hear from you. They won't come to you, you need to go to them. Why not go to NICE, go to NHS England, go to EMA? They're here and they want to hear from you. There's lots of patient advisory boards being set up. They're very informative and valuable, so be a part of them if you can. These are two families who I have consent, the same that I did with Sam, to share with you today that they're inspirational stories and they're still fighting now. So this is Lucy and Mike. They have 5 children, and 2 of their children have Batten's disease, a cruel progressive condition. And Amelia and Ollie were told at diagnosis that there was no approved treatment and that they weren't eligible for a clinical trial. So they were given nothing. So Lucy and Mike fought for compassionate use access to investigational medicine. They got it. They believe it saved their life and stopped the progression of the disease, and they're now part of a managed access agreement because they went to NICE and had their say, helped the data collection of their real life experiences, and are still fighting now for access for all Batten's families. This is Cheeky Maddox. He has HPP, another metabolic condition. This is Mum Merrill, who set up Soft Bones. They went to NICE as well because they had to fight for compassionate use and wanted to set up a managed access agreement to ensure that all HPP families get that access to that drug. And they were supported heavily by Metabolic Support UK. Couldn't have done it without them. So speak to Metabolic Support UK, speak to these families. They will share their experiences, share their stories with you, and you can learn a lot from them. And I truly believe together you are stronger. So just to summarise, because I covered a lot there, that randomised controlled trials are, so clinical trials are gold standard, and they are the pathway to approved investigational medicines. So they must be prioritised. We need safe and effective medicines to the metabolic community as soon as possible. If there is an urgent, life-threatening need, then early access is a pathway and is something to consider. But you must weigh up the benefit and the risk, and the benefit must outweigh the risk. This pandemic is extremely challenging, and we want to keep you safe, so please speak to your doctor if you're unsure about what appointments you have, or if you can leave the house, or what you can and can't do. Please speak to your treating physicians, treating clinicians, because they are the expert and they are there for you to keep you safe. COVID-19 has had a significant impact on clinical trials and early access programs, but there are ways to mitigate it. Home care and digital technology are definitely two things that can help address the challenges. But most importantly, you as patients and families need to work with patient organisations like Metabolic Support UK and your expert doctors to gain access to the clinical trials and the early access programs. Collecting all of your clinical information while on these programs can improve and inform the future care of patients. And don't forget, the patient voice is extremely powerful, and we're here to listen.
Thank you all to all our wonderful speakers. I think you'll all agree that every single one of them was incredibly informative. A couple of highlights that I picked from the talks. Elaine highlighted the daily challenges and constant change that has become synonymous with 2020. But despite those challenges and constant changes, I was able to glean some positivity from her presentation. Mainly that there were some indicators that patients had been taking higher level of care for their own health during this pandemic, and that COVID-19 specifically had not been a major threat to the health of the IMD communities. I particularly took heart that our patient community were also very thoughtful of the well-being of our doctors and healthcare professionals, as we all need to care for each other in these difficult times. Izzy reassured us that the natural human response to the stresses of 2020 can be to feel low, stress and anxious. As this is part of the new normal, we are not alone when we're experiencing these feelings. But emphasising on altruism can help, and our actions to safeguard others can actually help us to feel better too. I will certainly be focusing on the AAAs from now on: autonomy, altruism and authenticity. Naomi gave us a great insight into all the efforts going on to ensure that access to innovative treatment for rare disease patients and patients that need these treatments is well underway. She also highlighted that the rare disease patients are already living by this altruistic mantra and wanting to share their experience and to share their data in order to help the community to learn and to benefit the lives of others. While we may never wish for COVID, I hope that we can focus a little on some of the positive learnings that can be adapted and utilised as we move to the new normal. And when COVID becomes a distant memory, that we remember and learn from this experience to make sure that the new business as usual keeps some of these positive changes and the learnings that have worked well. So please do share your opinions, your views, your voice with the team at MS UK so that we can collate that and utilise it to empower others and support advocacy works of services moving forward. Because as Naomi said, together we are stronger. Thank you all for attending this webinar, and I'll now leave you for the rest of the conference.